Thank you very much to the organizers of the 39th Annual Meeting of the Japanese Society for AIDS Research for the opportunity to contribute to this year's program. I am honored to be part of this meeting. I also want to apologize for not being able to join you in person. Unfortunately, scheduling constraints required me to prepare this recorded presentation, but I am grateful to still be able to share these updates with you. In the next several minutes, I will provide a rapid overview of the key HIV drug resistance mutations, focusing on their mechanisms, how frequently they occur in treated populations, and their clinical implications for the most widely used antiretrovirals. I have no disclosures. For this overview of HIV drug resistance mutations, I will concentrate on the antiretroviral agents that are currently in widest clinical use. For the NRTIs, I will focus on the mutations selected by the most common backbones, tenofovir plus 3TC or FTC and 3TC monotherapy. In STIs, the emphasis will be on the second generation integrase inhibitors, dolutegravir, bictegravir, and cabotegravir. For the NNRTIs, I will highlight resistance to rilpivirine and the newer agent doravirine. For the PIs, the discussion will center on darunavir, which is the most widely used protease inhibitor. I will also review the drug resistance mutations associated with the capsid inhibitor lenacapavir. I will not cover entry inhibitors because they are used infrequently and because envelope sequencing is not routinely performed. I will also not discuss islatravir as it is not yet approved and there are no clinical data on islatravir-associated drug resistance mutations. For each drug, I will review the drug resistance mutations that occur most frequently in patients receiving that agent. Nearly all clinically significant drug resistance mutations are non-polymorphic, meaning they are rarely found in the absence of drug pressure. However, each drug class also has accessory mutations that do occur naturally in a small proportion of individuals. I will also summarize what is known about the major drug resistance mutations affecting in vitro susceptibility. In a few cases, I will highlight the relationship between specific mutations and virological response. These relationships can be difficult to interpret as response is influenced by multiple factors, including prior ART exposure, the baseline resistance profile, baseline virus load, regimen composition, and adherence. These data sets are also rarely publicly available because they require extensive baseline data and longitudinal viral load measurements. The top panel shows the distribution of NRTI drug resistance mutations in patients receiving tenofovir plus 3TC or FTC. The most commonly selected mutations are M184V and I and K65R. Several additional mutations, A62V, K70E, L74I, and Y115F, occur at lower frequencies. There is also a small background of thymidine analog mutations, or TAMs. It remains uncertain whether these TAMs are selected by tenofovir XDC or whether they instead reflect transmitted resistance or perhaps incomplete treatment histories. For bacavir 3TC, the pattern is broadly similar to tenofovir XDC, but with some key differences. L74F and Y115F occur more frequently, whereas K65R is less common. For AZT3TC, the most frequently selected mutations are the TAMs. Finally, the multi-drug resistance mutations, insertions at position 69 and Q151M, are very rare in these data sets and are seen mainly in individuals previously treated with older NRTI regimens. This slide summarizes the results of linear regression analyses in which each drug resistance mutation is treated as an explanatory variable, and the outcome is the log-fold reduction in susceptibility. For 3TC-FTC, M184VI, not surprisingly, caused the highest levels of resistance. K65R and the rare position 69 insertion also reduce susceptibility. For tenofovir, K65R is the primary resistance mutation. Additional contributors include the TAMs, especially T215F and Y, as well as the rare multi-drug resistance mutations at positions 69 and 151. In contrast, M184V and I increase susceptibility, and K70E, despite being common clinically, has only a minimal effect on tenofovir susceptibility. For abacavir, there are three notable differences from tenofovir: M184V and I, L74V, and Y115F each contribute significantly to reduced abacavir susceptibility. For AZT, resistance is driven by the TAMs and the rare multi-drug resistance mutations. Several mutations increase susceptibility, including M184V and I, K65R, L74V, and several of the K70 variants. This slide summarizes data for the common patterns of NRTI-associated drug resistance mutations. M184V and I are associated with high-level resistance to 3TC, low-level resistance to abacavir, and increased susceptibility to both AZT and tenofovir. Because M184V and I reduces abacavir susceptibility, many drug resistance mutation patterns show greater resistance to abacavir than to tenofovir. K65R alone causes a 1.8-fold reduction in tenofovir susceptibility, a level that is clinically meaningful. However, when K65R is combined with M184V and I, the reduction in tenofovir susceptibility decreases to roughly 1.3-fold, illustrating the mitigating effect of M184V and I. The presence of multiple TAMs, especially the M41L plus L210W plus T215Y combination, often referred to as type 1 TAMs, results in a 3 to 4-fold reduced susceptibility to tenofovir and abacavir. For tenofovir, this TAM-associated resistance is partially offset when M184V and I are present. In the earliest monotherapy studies, 3TC reduced plasma HIV-1 RNA by roughly 50-fold, or about 1.7 logs. Several trials also showed that even after M184V and I emerged, viral load remained about 0.5 logs, or about 3-fold lower than baseline. This modest residual activity appears to be clinically meaningful. In patients with stable virological suppression, dolutegravir 3TC generally maintains that suppression even among those with a history of M184V and I. This is based on 2 small clinical trials and multiple retrospective cohort studies. This is in contrast to dolutegravir monotherapy in patients with virologic suppression, where studies report a 7% rate of virological failure and a 3% risk of dolutegravir resistance. However, it is important to note that most of these studies examined patients who had several years of prior virologic suppression, and several of the studies required that there be no detectable M184V or I by Sanger proviral DNA sequencing. Perhaps the strongest evidence for the benefit of 3TC despite M184V and I comes from the ANRS Moby-Dip trial, which compared darunavir or lopinavir monotherapy with darunavir or lopinavir plus 3TC in virologically suppressed patients on second-line therapy. About 97% of these patients had a history of M184V and I, after developing virological failure on a first-line NRTI and NRTI-containing regimen. At 1 year, the risk of virological failure was 23% in the monotherapy arm versus 3% in the dual therapy arm, demonstrating the significant contribution of 3TC even when M184V or I had occurred. The top panel shows the distribution of INSTI drug resistance mutations in nearly 300 individuals who received dolutegravir and subsequently developed at least one resistance mutation. Almost 90% of these patients had a mutation at one of four signature positions: R263K, G118R, N155H, and Q148H, R, and K. E138K appeared frequently as an accessory mutation. A key point is that these four mutation pathways rarely occurred together. The same core mutations were also observed in patients with virological failure on cabotegravir, but the distribution differed. In CAB-treated individuals, Q148R was the most common primary drug resistance mutation, and a rare mutation, G140R, was reported in a single patient. There have been too few reported cases of virological failure in patients receiving bictegravir to generate similar plots to the one shown here. This slide summarizes the regression analysis evaluating how individual drug resistance mutations affect dolutegravir susceptibility. G118R, the second most common dolutegravir selected mutation, has the largest impact, producing roughly an 8 to 9-fold reduction in susceptibility. In contrast, R263K, the most frequent mutation, causes only about a 2-fold reduction in susceptibility. Mutations at position 148 have little effect on their own, but when combined with mutations at positions 138 or 140, they can lead to substantial reductions in susceptibility. Finally, L74I, a highly polymorphic mutation, has minimal effect on susceptibility to dolutegravir and to other second-generation INSTIs. This slide highlights substantial cross-resistance that exists among the three second-generation INSTIs. For nearly all drug resistance mutation patterns, CAB shows the greatest loss of activity, often with substantially higher fold reductions in susceptibility compared with dolutegravir. In contrast, BIC generally shows slightly lower fold reductions than dolutegravir for the same drug resistance mutation patterns. It is important to emphasize that the clinical significance of some individual mutations, such as R263K, which causes only about a 2-fold reduction in dolutegravir susceptibility, remains uncertain. This question will be addressed in an upcoming clinical trial designed to evaluate the impact of common INSTI drug resistance mutations on treatment outcomes. I'm now going to move on to the NNRTIs, focusing on rilpivirine and doravirine. Rilpivirine has gained attention because of its long-acting formulation, which is paired with the long-acting formulation of cabotegravir. The top panel shows the most frequent rilpivirine-associated drug resistance mutations in approximately 200 individuals with virological failure and emerging resistance. And the bottom panel shows how these mutations affect rilpivirine susceptibility. Rilpivirine has a low genetic barrier to resistance. The two most commonly selected mutations, E138K with or without K101E, are typically associated with just 2 to 3-fold reductions in susceptibility. Other mutations with much larger effects on susceptibility occur, but they are less common. The E138 Variants are particularly important for rilpivirine as they exert effects that are largely unique to this drug. Their specific fold changes were quantified in a monogram phenosens study reported in a 2011 workshop abstract. Among these, E138A is noteworthy because it is found in 2 to 5% of NNRTI-naive viruses as a natural polymorphism. Early clinical observations suggest that E138A alone may not impair response to long-acting cabotegravir rilpivirine, but more data are needed. Our understanding of doravirine resistance remains limited. As shown in the top panel, drug resistance mutations have been documented in only 17 patients, so the clinical evidence base is still quite small. Despite this, several canonical mutations at positions 106, 188, 227, and 318 are widely recognized to cause greater than 30-fold reductions in doravirine susceptibility, although F227C and L require a second mutation, most commonly at position 106. 3 additional mutations, G190E, M230L, and L234I, have been selected in vitro and or are also shown to produce very large decreases in susceptibility. Beyond the canonical drug resistance mutations, various combinations of non-canonical mutations can produce more modest reductions in susceptibility, typically 3 to 10-fold, but the clinical significance of these lower-level resistance patterns remains uncertain. The Stanford HIV drug resistance database contains sequences from nearly 5,000 previously PI-naive persons who have received lopinavir plus ritonavir, and from nearly 1,200 previously PI-naive persons who have received atazanavir, usually boosted with ritonavir. Of these, approximately 25% developed at least one PI-associated drug resistance mutation. For lopinavir, the key resistance mutations at positions 46, 54, and 82 do not confer cross-resistance to darunavir. Atazanavir has a lower genetic barrier to resistance than lopinavir or darunavir. 2 mutations, I50L and N88S, are notable because they confer high-level resistance to atazanavir, but do not reduce susceptibility to other PIs. By contrast, far fewer data are available for previously PI-naive patients with virological failure on darunavir, and among the 242 such persons, only 16 had one or more PI resistance mutations. Several of these were polymorphic mutations, and others likely represented transmitted PI resistance. Therefore, boosted darunavir appears to very rarely select for PI resistance mutations in previously PI-naive patients. The genetic mechanisms of darunavir resistance have been well defined since they were first characterized in 2008, and little has changed in our understanding since then. Darunavir resistance is driven by a group of major mutations at 7 protease positions, supported by accessory mutations at 6 additional positions. High-level resistance typically requires an accumulation of mutations, usually 2 to 3 major mutations combined with 2 to 3 accessory mutations. The figure on the right illustrates how these mutations affect in vitro susceptibility in a regression analysis. Findings from the POWER trials, which enrolled PI-experienced patients with substantial PI resistance, showed that a meaningful reduction in clinical response to darunavir generally required approximately a 10-fold decrease in susceptibility. Complete loss of darunavir activity occurred only at much higher levels of resistance. Nearly all sequences from patients with virological failure on lenacapavir contain one of three primary drug resistance mutations, M66I, Q67H, or N74D. M66I and Q67H typically appear first as isolated mutations and then are followed by additional accessory mutations. Mutations at position 70 can have major effects on susceptibility, but thus far have only been observed in combination with one of the three primary drug resistance mutations. Mutations at positions 105 and 107 behave as accessory changes, while the highly potent mutation L56I has only been identified in vitro. In ART-naive patients, these mutations are very rare, occurring in fewer than 1 in 1,000 patients, although Q67H has a slightly higher natural prevalence of about 0.5% in CRF01AE viruses. The table on the right summarizes the available phenotypic susceptibility data. Q67H alone causes an about 6-fold reduction in susceptibility and maintains normal replication capacity. There is debate about whether this mutation alone is sufficient to compromise lenacapavir's efficacy given its picomolar potency. N74D and K70 mutations and the combination of Q67H with accessory mutations leads to intermediate to high reductions in susceptibility, defined here as 10 to 50-fold for intermediate reductions and 50 to 250-fold for high-level reductions. But the very highest levels of resistance occur with M66I, either alone or in combination with other drug resistance mutations. M66I has a very low replication capacity, as shown here, of 4%. Very high levels of resistance also occur with the combination of Q67H plus N74D. This concludes my rapid overview of the most clinically important drug resistance mutations across all major antiretroviral drug classes. Thank you for your attention. The landscape of HIV drug resistance continues to evolve as treatment strategies change, and I hope this rapid overview has provided useful perspective on the key mutations shaping current clinical practice. If you have questions or suggestions, please feel free to reach out to our group at HIVDB team at list.stanford.edu.